Hi, hello and welcome on behalf of Sonova and Sonova's Audiological Care to our 8th Virtual Physician Symposium, the power of a proactive approach, enhancing health outcomes through hearing loss and tinnitus treatment. My name is Karen Sheperd and I am very pleased to be moderating this session on behalf of Sonova. Thank you for joining us. Please be aware that you may select a language of preference following the icon as shown here on the slide for the language that you would like to choose for your subtitles. At Sonova, our global audiology care network is your local partner in hearing care. We have more than 3,500 stores and clinics across the globe where we strive to keep improving the quality of aftercare well-being through hearing care and deliver best-in-class service and expertise with the most technology advanced solutions. In our previous 7 symposiums, we have been exploring with a panel of international experts such subjects such as the correlation between hearing loss and cognition, shedding light on the difficult topic of tinnitus, presenting the complexities of managing mild hearing losses, highlighting the future of hearing aid technology, and delving deeper into the topic of tinnitus and cognition. And most recently, we've explored the subject of artificial intelligence in hearing healthcare. Later on, we will send you a link to all of these 7 events so that you may watch them again at your leisure. If you have previously joined us, thank you for rejoining us. If this is your first symposium, you are very welcome. Thank you. And we hope that you will continue to join us and that these sessions bring value to you and to your patients. Today, we are going to be talking about the subject of cognition and social emotional well-being, the proactive diagnosis and intervention on hearing loss and tinnitus. During this 90-minute webinar, we will be presenting the latest research findings. We're going to start by exploring the subject of broader health issues and why a multidisciplinary approach matters. And then we'll look at how technology in rehab can support mental and cognitive well-being. And finally, we'll dive into the tinnitus subject, understanding impact and latest treatment innovations. So before we begin, we would just like to remind you that you may submit, and you are very welcome to submit questions to our panel, and we will come to these questions at the end in a live Q&A session. So please, as it shows you here, submit your questions through the Q&A session. This course brings you 1.5 hours of continual education credits. If your country has permitted and had these accredited, then you will also receive an email link for a quiz that you may need to submit to claim those points, and that will come to you tomorrow via email. At the end of this session, we will ask you for some feedback. And we would really ask you just to spend a few moments at the end to click on the link, as you can see here on the screen, or find the form to share that feedback with us so that we can continue to learn and improve these symposiums for you. So with no further ado, it gives me absolute great pleasure to be able to introduce our very first speaker, Dr. David Maidment. David is a senior lecturer in psychology within the School of Sport, Exercise and Health Sciences at Loughborough University. He is a chartered member of the British Psychology Society and research lead for the Division of Health Psychology. David's research interests focus on behaviour change interventions that aim to improve physical and psychological well-being in adults with long-term conditions and disabilities, including, of course, hearing loss. David has studied at Cardiff University, completing his BSc, MSc and PhD there, and has completed professional practices in Great Ormond Street Hospital and University College London. He also has worked as a research associate at the Medical Research Council Institute of Hearing Research and is a research fellow within the hearing loss theme at the National Institute for Health and Care Research Nottingham Biomedical Research Centre. So if that isn't enough, in his spare time, he has taken up a passion that he's had a dream for years, which is that of learning the piano. So he started just a year ago, but is already delighting in unwinding at the end of a busy day and showing off to his children what he has accomplished. So David, thank you for joining us. David will share with us now sound advice for staying healthy, promoting holistic health in adults with hearing loss. David, thank you very much.
Thank you, Karen. That was an amazing introduction. So thank you very much for that. And I just want to say it's a great pleasure to be here today to present some of the work that we've currently been undertaking at Loughborough University, looking at the associations between hearing loss and general health more broadly. Now, before I begin, I just want us all to pause and reflect and think about, where are you on this continuum? So how important do you think hearing is to our general health? Perhaps you don't think it's important at all, so you might rate it as 1 or 2 stars. Perhaps if you're a psychologist like me, and we always like to sit on the fence, you might be uncertain, so maybe 3 stars. Or perhaps I don't need to convince you today, and you definitely are an advocate for the associations between hearing loss and general health. So hopefully by the end of this very short presentation, I hope to convince those that are probably lower on this scale how important our hearing is to our general health. And actually, if we look at a growing body of evidence, there's work to suggest that hearing loss, particularly in middle-aged and older adults, is associated with lots of different conditions, health conditions. So research has shown that hearing loss can actually increase the risk of adults developing other chronic health conditions, including diabetes, cardiovascular disease. It can also result in poorer psychosocial well-being, so it can have an impact on our emotional and mental health. So we see increases in terms of depression, loneliness, and social isolation, which typically arise as a consequence of the communication difficulties of hearing loss. And as Karen mentioned, there are other symposium that have explored the associations between hearing loss and increased risks and associations with cognitive function, primarily cognitive decline and dementia. So what I'm showing you here really is that hearing loss is associated with both our physical health, our psychosocial or emotional health, as well as our cognitive health also. Now, something that I'm really interested in is how healthy lifestyle behaviors can actually mitigate these risks in adults. And interestingly, what research has shown is that physical activity in particular can reduce the risk of developing chronic health conditions, can improve our psychological well-being, and also can reduce declines in cognitive impairment and dementia. So really what we're interested in exploring is how is it that we can see whether we can see associations between physical activity or declines in physical activity and function in adults with hearing loss. Now, I want to acknowledge that we aren't the first to explore this, and actually there is a huge body of work looking at all of these different associations, and that's what I'm showing you here in this schematic. So I've tried to map this out for you. But as you can see, with all of these arrows going in lots of different directions, hearing loss is kind of associated in lots of different areas, lots of different directions, and actually the picture is quite complicated. Nevertheless, growing research from other areas of the world have shown that older adults with hearing loss actually engage in substantially less physical activity each day compared to those with no hearing loss. And what I want to highlight here is that these are age matched individuals. So these are older adults that do or don't have hearing loss. And what we typically find is those that have a hearing loss, they engage in much less physical activity, which can range between 5 to 30 minutes each day. Now, that might not sound like very much, but actually these researchers found that this can result in substantial accelerated aging, so up to 10 years of accelerated aging for adults with hearing loss. So what this is really highlighting to us is that individuals with a hearing loss can become much frailer from an earlier age. And also this can increase their risk of developing more life-threatening chronic health conditions, as I've mentioned, things like diabetes, heart disease, and dementia. Now, we've also explored this. So fortunately, we had access to a large data set. So this is secondary data analysis that we undertook, looking at the English Longitudinal Study of Aging, or ELSA. So this is a study that was undertaken in England, in the United Kingdom, and this has tracked older adults who were aged over 50 years or above across a 22-year period. At the start of the study, over 11,000 individuals took part, and they've been very closely monitored and completed lots of different outcome measures across 20 years. So what I want to highlight here is that individuals typically report or undertake these measures every 2 years, and we call these waves. So we start at wave 1, which is the first year, and each wave is a 2-year increment. What I'm showing you here in the figure is some data that we analysed. So we wanted to compare individuals that had no hearing loss when they were aged matched to those that had hearing loss across that 20-year period. And what we interestingly found is that physical activity, irrespective of hearing loss, declines with age, which is perhaps unsurprising. Nevertheless, what we found is that physical activity actually declines much more rapidly and significantly in older adults with hearing loss. We were also able to monitor the exact time in that 20-year period where individuals reported having a hearing loss. And what we found is that those before they reported hearing loss typically met physical activity recommended guidelines. However, after the onset of their hearing loss, their physical activity substantially declined, indicating that perhaps there is a close association with hearing loss diagnosis and declines in physical activity. So building on this, I was actually really honoured and delighted to be invited to work with some world-renowned researchers across the globe, where we published this paper looking at new horizons in holistic and person-centred care with regard to hearing loss. And based on the available evidence that we had at that time, we advocated that there is a real strong need to promote hearing health and minimise the negative health impacts of hearing and related comorbidities. Nevertheless, we recognised that hearing professionals often lack awareness of general health impacts and hearing loss. So therefore, there is a need to increase awareness of a range of health conditions that are associated with hearing loss. In addition, there's a need for hearing healthcare professionals to be working together as part of an integrated interprofessional team. And ultimately, this can ensure that a holistic, person-centered care is delivered to older adults with hearing loss. So that's great. We've identified there are needs to improve awareness and for hearing healthcare professionals to work with other healthcare professionals. But how is it that we go about actually implementing that in practice? So what I wanted to do now is to highlight a project which is still somewhat ongoing, so hot off the press here. And what we wanted to explore is how likely is it that hearing healthcare professionals specifically can encourage healthy lifestyle conversations in their clinical practice with older adults with hearing loss. So for this study, we wanted to assess the perspectives and experiences of hearing healthcare professionals with regards to these domains. We also wanted to assess the awareness of service users, patients, adults with hearing loss. And ultimately, building on all of this information, we wanted to develop consensus in terms of how we can implement specific guidelines, specific recommendations into clinical practices. So we really followed a multi-step approach to this study. So our first aspect of this research was to recruit hearing healthcare professionals and older adults with hearing loss. And we undertook one-to-one semi-structured interviews in order to explore their awareness, their perceptions and experiences of the relationships between hearing loss and associated conditions, as well as to explore hearing healthcare professionals' willingness to promote healthy behaviours in clinical appointments. As a very quick summary, given the time, what we generally found is that adults with hearing loss were not aware at all of the links between hearing and their general health. Hearing healthcare professionals were somewhat aware of a link between hearing and other health conditions, but these mostly focused on dementia and cognitive decline and didn't tend to focus on other physical health conditions. And also hearing healthcare professionals were very unsure about how they could appropriately inform and enter into discussions with their patients, with their service users, in order to promote healthy behaviours in clinical settings. So with this in mind, what I wanted to highlight is that some hearing healthcare professionals were definitely on board with our message. And I have a quote here from one who said that a hearing healthcare professional's role is really to educate people to take care of themselves. There are so many touch points across the health and well-being spectrum in relation to hearing loss. If we simply isolate hearing and just think of it as a barrier to communication, we're not really treating the whole person. So with that in mind, current work that's currently ongoing is an electronic Delphi study, which is really a study where we undertake several different rounds in order to develop consensus among our panel of experts, who in this case are 25 UK-based hearing healthcare professionals, some from the publicly funded National Health Service, some from the independent sector. They range in years of experience. And what I will say here is we're currently at round 3, the final round. And what we're doing here is we're wanting to see which statements, which recommendations they support. And we're looking for 80% consensus, ideally. So if I give you some top level findings that we found from our first 2 rounds, most hearing healthcare professionals have agreed that it is important to discuss general health with their clients or patients. They also feel that it's important to collaborate with other healthcare professionals when discussing general health, but they really find that they lack the knowledge and the skills to enter into these discussions and would like further training to embark on those. Interestingly, we found nearly 60% already said they engaged in some discussions about general health, but a minority said that they should be assessing general health and actually felt that general practitioners, doctors were probably better suited for this. So to summarize, hearing loss and physical activity, why should we care? So if we go back to those ratings at the start that I got you to think about, hopefully I've convinced you now that hearing loss in adults is really important and is associated with multiple health conditions, and healthy lifestyle behaviours can actually reduce or mitigate the risk of developing these conditions. Cross-sectional and longitudinal evidence suggests that physical activity actually declines much more rapidly in adults with hearing loss. But some outstanding questions that we hope to explore in the future are whether tailored healthy lifestyle behaviour interventions are needed for hearing loss specifically, and whether clinical appointments with hearing healthcare professionals would be the best time to discuss general health with adults with hearing loss. So finally, I want to thank you all for your attention. I want to acknowledge the people that have made this work possible, and especially Sonova for supporting this research, as well as the audiologists at Boots Hearing Care who kindly gave their time to take part in aspects of our projects. Thank you all very much.
Thank you very much, David. And just as a reminder, if you do have any questions for David, please post them into the Q&A chat and we'll come to them at the end of the session in the live Q&A. So I would now like to introduce you to our second speaker of the evening, Dr. Beck Bennett. Dr. Beck Bennett is a senior research audiologist at the National Acoustics Laboratory in Australia. Her research focuses on adult audiological rehabilitation, the social and emotional impacts of hearing loss, and e-health service delivery. Beck is currently leading a program of work to develop a digital self-management tool to address the social and emotional impacts of hearing loss. Beck tells us that in her free time, I'm surprised that all these people are so busy, have free time, but in her free time, she likes to unwind at the end of a busy day, doing yoga of all sorts, from Bikram to Vinyasa to Yin, and it really helps her both mentally and physically to unwind. So today in this event, we're going to hear from Dr. Bennett about the hidden impacts of hearing loss addressing mental health. Now, I mentioned that she's in Australia, so due to the time zone differences, she's unable to be with us live, but we will now play a pre-recorded presentation. So please sit back and relax. And if you have questions for this presentation, I'm sure we can pass those across to Dr. Bennett directly to get them answered. So please enjoy the recording of Dr. Bennett's.
Thank you. Yes, so I'm Beck from National Acoustics Laboratories in Australia. So I'm very fortunate to live up in Queensland on the Sunshine Coast. This photo here is my little beachfront area, and also exceptionally lucky to be able to fly into National Acoustics Laboratory based in Sydney here every month to work with my colleagues. And so I've been asked today to talk about some of the research of my team and my colleagues to do with one of the, I guess, hidden impacts of hearing loss, and that's that kind of social and emotional or mental well-being impacts of hearing loss. So I've broken up today's presentation into kind of 6 topics, the 6 sort of main domains of well-being that are affected by hearing loss, and the first one being employment challenges. So we do see a higher unemployment and also underemployment rates in people with hearing loss. And this includes both lower skilled as well as they're often receiving a lower pay than their normal hearing counterparts. We also see this sort of play out in the workplace in that adults with hearing loss are more often reporting higher rates of sick leave or disability leave, and are often retiring earlier than their normal hearing counterparts. When we have interviews with adults with hearing loss to explore how they experience those sort of workplace challenges, they talk about receiving or experiencing greater workplace stress, also greater fatigue at the end of the day, and feeling quite isolated within the work environment where their peers and also their managers are not understanding how difficult they find it in that workplace. So if we sort of try to think about and understand how hearing loss might be impacting on their sort of employment opportunities or employment performances or ability to function in the workplace, we can see quite clearly that one of the key barriers is around this sort of communication barrier. So difficulty hearing conversations, difficulty following multiple speakers or in a noisy environment in meetings, and difficulty in phone conversations. And also, as we're now, a lot of us moving on to this online world, we're finding that adults with hearing loss are also having greater difficulty hearing through video conference calls than normal hearing counterparts, and they experience their fatigue much sooner than normal hearing counterparts in this online communication environment. We also see the impact of hearing loss resulting in increased cognitive load. So they're needing to put more effort in to listen, and this can lead to exhaustion at work and especially after work as well. And there's often this sort of employer misunderstanding, so a lack of awareness and a lack of accommodation within the workplace. So if we look at some of sort of the early indicators of how hearing aids and hearing devices can help, we can see that in the workplace there's increased safety when people use hearing devices because they have better awareness of warnings, alarms, and those sort of environmental sounds. We also note that people have improved speech clarity, which makes it easier to follow conversations and then perform better in the workplace. We know that people start to talk about they experience less listening effort, so they have less fatigue and they're able to better focus and have higher productivity at work once they start using their hearing aids. And they have greater workplace participation, so they feel more confident in those sort of team interactions in the workplace. So that brings us to the second impact, which is social isolation. So we know that untreated hearing loss leads to higher risk of social isolation. People with hearing loss have 2.14 times greater odds of experiencing social isolation than their normal hearing counterparts. And this sort of plays out as reduced participation in social and community activities. We also find that there's a higher social isolation in women with hearing loss than in men. And also we can see that the more severe the hearing loss is, the greater the isolation. Now, if we start to think about how hearing loss contributes to social isolation, the obvious one is the hearing deficit, the difficulty following conversations in those social environments, and this can lead to frustration and withdrawal. We also hear people with hearing difficulties talk about this concept of withdrawing from social activities and also withdrawing within social activities. So it might be that people avoid going to social activities altogether, that avoidance from, or that they might still attend, especially if they have a partner that drags them along to the dinner parties or whatever. They might still attend the social event, but they might withdraw within the social event by kind of tuning out, zoning out, or just smiling and nodding, sitting back and not actually participating in the conversation. So we can have that kind of physical social isolation, or we can physically be present, but have that sort of mental and emotional isolation within that social environment. And then, of course, there's a really important role that family and friends play. So we have instances where the individual with hearing loss will withdraw themselves from social participation, but we also have instances where the family or the friends will reject or exclude or kind of isolate the person with hearing loss, not inviting them because it might be too hard for them to hear anyway, or only inviting them when it's at a quiet restaurant rather than not at a busy restaurant, or talking over the top of them and excluding them from the conversation if they're struggling in a particular environment. And so as healthcare professionals, it's really important that we take this sort of family-centered lens to hearing loss management, and that we take the opportunity to also educate the family and friends that might be attending appointments, and empower our clients to be able to educate their family and friends to help them understand their role in the impact they're having on social isolation they might be experiencing. So how can hearing aids help with social isolation? Well, they can help improve the ability to follow conversations, which can increase social confidence, make people participate more, and also they reduce listening effort, making socializing less tiring. We come to loneliness now, which of course is the sort of the subjective or the sort of self-perceived experience of disconnection in those social settings. And we also see that there's a higher rate of loneliness in adults with hearing loss than their normal hearing counterparts. Again, women have a greater odds or greater risk of loneliness than men with hearing loss. We also see that the risk of loneliness is comparable to smoking in its negative impact on health and well-being. And so loneliness is a huge problem in adults with hearing loss, and very worthy of our attention. If we start to think about how hearing loss may contribute to loneliness, it's quite similar to what we just discussed in that social participation or social isolation phenomena. So we're seeing difficulty hearing or struggling within those conversations, leading to frustration and feeling disconnected and misunderstood. And also that difficulty with the increased cognitive load, making socializing exhausting. And so people with hearing loss often feel like they're left out, or they're not keeping up with the conversation, and they feel alone in their experience in that social environment. So how might hearing aids help with loneliness? Well, we're starting to see some really good research come out now that shows that people who use hearing aids have a reduced experience of loneliness compared to people with hearing loss that do not use hearing aids. So we're starting to see that hearing aid use is a factor in helping people better manage their loneliness experiences. And we anticipate that some of the sort of mechanisms of action here would be around the improved hearing, so it's easier to stay engaged in those social environments, improved communication, building that sort of participation behaviours, and also, as we've talked about, that reduced listening effort. So less fatigue and more energy at the end of the day to get out there and actually socialise with your family and friends. Let's talk a little bit about anxiety. So there is a higher prevalence of anxiety disorders in adults with hearing loss as well, although I will say the research on this topic is limited. But the research that is available suggests that 15 to 31% of people with hearing loss experience significant anxiety symptoms, and that this is greater in people with greater severity of hearing loss. We also know quite well now that people with tinnitus or hyperacusis also experience heightened anxiety. We're still trying to understand the mechanisms of action of how anxiety symptoms come about with and how they are greater in adults with hearing loss. And we expect that it's to do with, again, the communication difficulties, the increased cognitive load, and the sort of tinnitus and hyperacusis that these individuals are experiencing. So if we think about how hearing aids might help people with hearing loss in better managing their anxiety symptoms, again, we can look at the improved communication that they experience, that reduced cognitive strain. But again, there's quite limited research on this topic, and so we do need more research on anxiety to better understand this phenomenon. What we do see, though, is not only do people with hearing loss treated with hearing aids have less anxiety than those with untreated hearing loss, but we also see that when people combine hearing aid treatment along with other rehabilitation and support group type programs, that they have more improved mental well-being. And so it looks as though from a sort of clinical advice perspective, that our role is to connect people not just to hearing aids to better manage their anxiety symptoms caused by hearing loss, but also other supports that they can action in parallel. If we look at the research on depression, we see that hearing loss increases risk of depression by 39 to 54%. So we're consistently seeing a higher rate of depression in adults with hearing loss than their normal hearing counterparts across studies and meta-analyses. We also see that there's more severe hearing loss leads to higher depression rates. So there's a strong correlation there. We don't yet fully understand the mechanisms of action, but again, we anticipate that the link between hearing loss and depression is associated with that sort of increased cognitive load, mental exhaustion and stress that people with untreated hearing loss often experience. Also that reduced activity engagement and that sort of social isolation and loneliness that they experience, resulting in adults with hearing loss sort of disconnecting and having less social engagement, less mental stimulation, and also a lack of social support. We do find that adults with untreated hearing loss have smaller social groups and less social support than their normal hearing counterparts. And this is also an indicator that we see in adults with depression. So there could be a link there. There are some studies starting to come out that show that people who use hearing aids to better manage their hearing loss also have lower rates of depression than those people with hearing loss and no hearing aid use. So there is some early indicators that hearing aid use might be a protective factor for depression. And some of the mechanisms of action here are potentially around, again, improving that sort of communication and encouraging and supporting that social engagement and social participation, but also that lens of reducing cognitive strain, less mental fatigue, and providing that sort of sense of control that they can manage their hearing loss, their chronic hearing loss condition that they're experiencing. Moving on to cognition, we also see that people with untreated hearing loss have a higher risk of cognitive decline and dementia. And again, this risk increases with the severity of hearing loss. There are a number of studies starting to come out now, but we are finding mixed results as to how hearing aids interplay with that sort of high risk of cognitive decline in adults with hearing loss. So we anticipate that, again, it's the increased cognitive load or sensory deprivation or reduced social engagement that may be the mechanisms of action contributing to that high risk of cognitive decline and dementia in adults with hearing loss. But there is still a lot of research needed to better understand whether hearing aids may be able to slow that cognitive decline or delay or affect that progression of cognitive decline in adults with hearing loss. Some of the current thought processes are around hearing aids may reduce listening effort, encourage social engagement, and improve speech processing. But again, there's still more research required in this area. So I'd like to show you a little video that we've put together that is a recording of a few different adults with hearing loss that talk about their experience of hearing loss, and they talk about how their hearing loss has impacted on their mental well-being. For some of these people, it impacts on their social connection, their social circle, their experience of loneliness, also how other people might view them. I imagine a lot of you work with adults with hearing loss and hear similar stories, but I would love to share this with you so that you can sort of really feel the emotion and feel the gravity of their experiences in the stories that they share.
I do feel excluded because sometimes you hear conversations and laughter and you're not part of it. You hear bits of it, but not the whole conversation.
When I gave up work, I was devastated. You know, I was at the top of my game in a fabulous career, and I had to give it up because I just had to deal with the ear health, had to. There was nobody I could talk to about how devastated I felt.
Loneliness is an issue that comes with hearing loss. Two people are having a conversation and you're a third party in the conversation, and they're talking, and I'm thinking, what on earth are they talking about? In order to avoid having to communicate with people, I'd rather just be by myself.
I almost play cryptic crosswords when I'm listening to people because I hear a word, I've got to make an interpretation as what that word was, and I can quite often get the wrong meaning. I have been embarrassed in that scenario.
Without realising it, I probably speak quite loudly now. I mean, a guy walked in that I didn't know, and I turned to my daughter who was sitting next to me and I said, "Oh, is that so-and-so?" But apparently I said it in a very loud voice, and she said to me, Mum, you know, you're speaking too loud. And that was very embarrassing in that situation.
I would say that I have felt excluded at most social gatherings, even with hearing aids, despite telling people that you are hearing impaired or deaf, they don't change their behaviour. And I've got to the stage now where I actually avoid large gatherings. I don't mind going one-on-one or one-on-two, and that's about my limit, because you get tired of saying to people, I can't hear you, I can't understand you.
Usually I just sort of think, how long is this going to last? Hopefully it won't be too long.
You know, when you're somebody who has always enjoyed being social, who's enjoyed networking and things like that, it's a bit of a shock to your system.
My wife might be watching a TV program and she'll suddenly laugh, and I say, what happened then? And she'll say, I'll tell you later, because otherwise she'll miss the rest of the program, obviously. And most of the time later doesn't come, so as a result there tends to be that issue of exclusion.
It's a continual frustration in our day-to-day life. It doesn't matter how long you live with someone who's deaf, you think they're not. You're not aware of it all the time. You just think they can hear like you. So I'm continually repeating everything I say, because even though I'm aware that he's deaf, it's not something that's embedded in my brain.
My audiologists have never discussed the feeling of isolation or loneliness that I have with hearing loss. I don't think it's ever occurred to them to discuss it.
I guess it's not something that, you know, when you go there and you have a hearing test, don't necessarily think of things like this.
It would be great if an audiologist could take you a little bit further down and the path on the other emotional side, not just the physical hearing aid side.
If my audiologist had tips that could help me in certain situations, I'm sure I would gladly receive them.
So I'm sure you've experienced similar stories, or you've heard similar stories from some of the clients that you've worked with. I must say Doug's story especially really touches me, and how he talks about that sort of experience of loneliness within his marriage, within the experience of watching TV together as a couple, something that seems sort of so benign but can carry such gravity for him. And so I really encourage you, if you're not currently opening that safe space for your clients to think about and reflect upon and talk about the social and emotional or mental well-being impacts of their hearing loss, then I'd really encourage you to do so, because creating that safe space for them allows them to reflect, and then creates an opportunity for you to validate their experiences and help them to realize they're not alone, and then perhaps be part of that process of helping them connect the dots and identify what the next steps might be, how they might access the help they need to better manage those social and emotional well-being impacts. So let's have a quick little think. How perhaps might you better support the well-being needs of your clients? Well, a couple of ideas. One might be to acknowledge the emotional impact, to validate your client's concerns around that sort of frustration, anxiety, or social withdrawal. Another might be around encouraging early intervention, so prompt referrals for hearing assessments and hearing rehabilitation options. There might be a third around sort of discussing hearing aids and assistive devices and explaining the benefits, not just of hearing better, but how improved hearing can also relate to improved communication and overall social and emotional and mental well-being. You may also promote social engagement, so encourage your clients to participate in support groups or community activities. Help them understand that hearing aids alone may not address all of these mental well-being impacts, but if they can put together a plan for themselves of how to sort of rebuild those social networks, how to rebuild those relationships with individuals and get out there and participate more socially, that they'll receive better overall well-being benefits. And then finally, the fifth might be to consider referral for mental health support. If you're working with a client who is experiencing quite significant symptoms of isolation or loneliness or anxiety or depression, then it's really important, our role as health practitioners is to refer them on to mental health support, whether that's sort of counselling, psychotherapy, or audiology-based therapy, or peer support. But to be that sort of open door and help them find the right pathway to the support that they're looking for. So thanks for your attention today. If you have any questions, you can find me at National Acoustics Laboratory. Here's my email. And I look forward to seeing you all one day again soon. Thanks so much. Ciao.
Great. I hope you enjoyed that presentation from Dr. Bennett. So now it is my great honour to introduce our last speaker for the event today, Professor Berthold Langus, who is Deputy Director of the Clinic for Psychiatry and Psychotherapy at the University of Regensburg and the Director of the Multidisciplinary Tinnitus Clinic at the same university. In 2006, he co-founded the Tinnitus Research Initiative and is still the chairman of the board today. He has specialist qualifications in neurology, psychiatry, psychotherapy, and specialized pain medicine. His research focuses on understanding the pathophysiology of neuropsychiatric disorders such as schizophrenia, depression, and tinnitus, as well as the development of innovative treatments. His research group focuses on brain imaging, non-invasive brain stimulation, clinical research, e-health-based diagnostics and therapeutic approaches, data management and analysis. Impressively, he is co-author of no less than 425 articles and editor of 8 books on brain stimulation, clinical neuroscience, neurology, psychiatry, tinnitus, and digital health. He has been listed in the Expertscape consecutively from 2021 to 2024 as the world's most eminent expert in tinnitus and or hearing disorders, and is regularly listed among the top physicians in Germany for depression, anxiety disorders, and schizophrenia. So a very impressive resume, but even to top that further, 25 years ago, a very impressive, not just any old triathlon, but one that took him across Switzerland, swimming across Lake Maggiore, cycling over the Great St. Bernard Pass, and running from Zurich to Rhine. So it's my very great pleasure to welcome Professor Berthold Languth to give us a presentation now on tinnitus from science to clinical best practice. Thank you so much, Professor.
So thank you very much for this very friendly and nice introduction. And just the moment when you introduced me, the windows change here and the sun comes in. I hope that you still can see me very well. So it's my great pleasure to talk to you today about tinnitus, and the goal is to introduce our knowledge about tinnitus and the translation into clinical best practice. So I'm based in Regensburg, which is a very small but very nice German city in the southeast of Germany next to the river Danube. As mentioned, I'm dealing with tinnitus for a long time, and an important first question is always, how frequent is tinnitus? And very recently, we performed a meta-analysis about epidemiological studies, and what we found is that tinnitus is really a very frequent condition, but it's very important to distinguish between people who experience a phantom sound, who experience a tinnitus. This is about 15% of the population, and those people who are really bothered by the tinnitus, who have a significant impairment in their life because of the tinnitus. And I think this is a phenomenon what many people who deal professionally with tinnitus patients know and experience, that there are many people who have tinnitus, but luckily only a smaller number of people who are really severely impaired and distressed by the tinnitus. I'm a psychiatrist, and we have some patients who come to the hospital because they want to commit suicide. They cannot cope with their tinnitus anymore. But there's a big problem that at the moment, when we give a diagnosis to a patient, we call all this tinnitus independently, whether it's just a perception of a sound, which is not disturbing, or whether people are severely impaired. And for this reason, together with experts from all over the world, we tried to come up with two different definitions and to distinguish tinnitus and tinnitus disorder. So according to our proposition, tinnitus is a conscious awareness of a tonal or composite sound noise for which there's no identifiable corresponding external sound source. So that's more or less the current definition of tinnitus. And we wanted to identify tinnitus disorder as a condition when this percept of the tinnitus sound is associated with emotional or cognitive dysfunction, autonomic arousal, leading to behavioral changes and functional disability. So for us, it's important to acknowledge the fact that some people just perceive the sound and others are severely impaired. And I think we have to deal with these two groups of patients in a different way, and we also have to put different diagnoses for these two different conditions. So, in order to understand the neuroscience of tinnitus, the neurophysiological correlates of tinnitus in the brain, we have to understand hearing and have to remind what is happening when we hear something. We are all well aware that hearing loss is the most important risk factor for the development of tinnitus. So if we hear something, the cochlea converts sounds into nerve signals, and this information is transmitted to the brain via the auditory nerves. Within the central auditory pathways in the brainstem, in the middle brain, and the thalamus, these signals are further processed. And finally, they are represented in the auditory cortex. And there's a huge amount of evidence that in the case that there's not sufficient information coming into these central auditory pathways because of hearing loss, then the brain tries to compensate for this lack of input. So in case that we have some form of hearing loss, the signals that are still there are increased, they are amplified. And this amplification of the remaining signals probably is very important for the generation of tinnitus. However, when we look with functional imaging methods on patients with tinnitus, we do not only see changes in the central auditory pathways. So here you see a summary of imaging findings from patients with tinnitus. And yes, we see changes in the central auditory pathway, here marked in green. But we also see changes in many other parts of the brain, in brain networks that are related to perception, to salience, which means giving meaning to a percept, and also with networks that are related to distress and memory. So this demonstrates that the tinnitus, and these were mainly patients suffering from tinnitus, is not only an aspect of perception, but it's also an aspect of emotional load, and also has an impact on memory. So how can we explain all these different involvements of brain networks? And I think it can be simplified in a certain way that first, due to hearing loss, we have increased activity in the auditory pathways in order to compensate the lack of input. But this alone is not sufficient for an auditory percept. Only if the activation in the auditory cortex is related to the attention network here in blue, we perceive the tinnitus. And only if you have an additional activation of the stress network consisting of the amygdala, of the insula, of the anterior cingulate cortex, only in these cases the tinnitus is also perceived as stressful. And this model can explain that there are some people who have hearing loss without any tinnitus. In this case, you have only increased activation in the auditory cortex. As soon as it's connected to the blue network, to the attention network, you perceive a tinnitus. And as soon as this activity is connected to the stress network, you perceive the tinnitus as stressful. So this explains these different types of tinnitus that we see also in the clinics. So based on that, we tried to come up with an algorithm for diagnosis and treatment of chronic tinnitus. And I have to be, due to the lack of time, be short here and cannot go through the complete algorithm. But what is important is that at the beginning of the management of every tinnitus patient is the diagnostic assessment, consisting of the case history, consisting of an audiological assessment, and then clinical evaluation by the ENT mainly. All this should be accompanied by insightful counseling, because for sure patients are worried, they are concerned, they perceive a sound. So we should always provide the necessary information to explain them what are the mechanisms that create the sound, so that's easier for the patient to understand what is happening in his situation. For sure, this is not sufficient in many patients, especially in those who are suffering a lot. And here it's important to look on comorbidities like vestibular problems, hearing problems, psychiatric problems, and always we should try to address these additional health problems that are related to tinnitus. I think a very specific focus is the compensation of hearing loss. We come back to that later, but as I have explained before, in most cases the hearing loss is the initial cause of the development of the tinnitus, so for sure it makes sense to compensate for this hearing loss. But among the treatments that are best evaluated is cognitive behavioral therapy. And this refers to the fact that people are not suffering from the sound, but suffering from the emotional reaction to the sound. This is not clear for the patient. You have to explain it to the patient, because for the patient, the sound is there, and you have all these dysfunctional beliefs. I feel miserable because of my tinnitus. I cannot imagine that I tolerate a situation that worsens my tinnitus, and I really want to get rid of my tinnitus. So for the patient, the tinnitus percept and the reaction to the tinnitus as something that is very stressful, very bothersome, is connected. And we have to explain to the patient that it's possible to disconnect the percept from the emotional reaction. And for sure, the patient cannot do it alone, but the cognitive behavioral therapy helps the patient to learn how to perceive the tinnitus from a different perspective and how to disconnect the tinnitus percept from the emotional reaction. So going back to the cartoon we had before, we try to disconnect the stressful reaction from the tinnitus percept, and this works. Studies show that people who undergo cognitive behavioral therapy get better. They have better abilities to cope with the ongoing tinnitus. The tinnitus percept is not changed very much typically, but the reaction to the tinnitus is a different one. The next important aspect of tinnitus treatment is the compensation of hearing loss and sound therapy. And there's different concepts. For sure, in most cases, there's an indication for hearing aids. It's an ongoing question whether tinnitus is an indication for a hearing aid in addition to the already consisting hearing loss. So given the case that somebody has a hearing loss, for example, in the high frequency range, but has still satisfying speech perception, normally you would not prescribe a hearing aid. But in case of tinnitus, it might be helpful. We have not very good studies on that, and I think that it's a gap of knowledge at the moment. But from a theoretical perspective and from our clinical experience, in these patients with high frequency hearing loss but normal speech understanding or normal hearing in the middle frequencies, also hearing aids can be helpful. Very impressive are the results from cochlear implants. So here we have sometimes patients who are completely cured after cochlear implantation. So typically we have severely hearing impaired tinnitus patients with one-sided deafness, with unilateral tinnitus, and in some cases after cochlear implantation, the tinnitus is completely suppressed as long as the cochlear implant is activated. There also have been many other approaches that have been proposed to use sounds in a specific way in order to change the activity in the central auditory system with some specific sounds presented in a certain way. So there was a coordinated reset therapy, the notched music treatment, but all these approaches have not fulfilled the promise they had in the beginning. So none of these treatments has received a status as a routine treatment for tinnitus patients. The same is true for the masking devices. So even for the masking devices which are routinely used, the evidence for their effectivity is unfortunately very low. In order to better understand what is the relevance of the different treatments that are available, we performed a large study, multicentric study in 5 centers in 4 different European countries with almost 500 patients. And what we wanted to find out is whether these standard treatments like counseling, like cognitive behavioral therapy, like hearing aids and sound therapy, how well they work if we compare them to each other, and whether they should be recommended alone or in combination. So altogether, we had 10 different treatment arms because we combined all the different treatments with each other and also tested them alone. Some of the treatments were app-based, such as counseling. So it was app-based counseling. Cognitive behavioral therapy was offered as a group treatment. Hearing aids were normal hearing aids. And also the sound therapy was offered as an app-based treatment. The patients had the ability to choose one out of 64 different sounds that were offered. And here you see the results. So I won't go through all the 10 different treatment arms. What you see on the left is sound treatment alone, and you see on the y-axis the Cohen's d, the effect size. So the lowest effect was found for sound therapy alone. That was very, very small effect of the treatment. And then the other treatments alone, cognitive behavioral therapy, hearing aids, and structured counseling, they are in the red box, and there you see quite a similar effect. So cognitive behavioral therapy worked. We knew this from studies before. There was good evidence for that. But structured counseling and hearing aids had an effect in a very similar range. On the right side, you see some more effective combinations. So under some conditions, the combination of different treatments was even better. For example, hearing aids plus cognitive behavioral therapy and so on. So I think it's useful to combine different treatments, but what you can keep in mind, counseling, cognitive behavioral therapy, and hearing aid are all very useful treatments. Sound therapy, unfortunately, is not as efficient as we expected. We also have to be aware that these group data, so in individual, sound therapy can be helpful, but here in the study, it was not. So there's a third important approach for tinnitus treatment, which is neuromodulation or neurostimulation. This approach is based on the idea that we have some changes in the brain that are responsible for the perception of the tinnitus sound, but also for the suffering from tinnitus. And if we are successful in changing this brain activity, it also should reduce tinnitus. Many different approaches have been tested, and I think the best results are seen with bimodal neurostimulation. It's the combination of electrical stimulation to the face area, to the tongue, and auditory stimulation. So there's studies with different approaches which all show very promising results. But I think that's still a treatment under development, not on the same range like hearing aids, cognitive behavioral therapy, and counseling. So I come to the end, and I would like that you take home some messages. So tinnitus is a very frequent disorder, but it's important that we distinguish between treatment with and without suffering, tinnitus for tinnitus alone, and tinnitus disorder for tinnitus connected with suffering. From neuroscientific research, we know that tinnitus involves various brain areas, probably depending on the exact situation in an individual. For sure, people who suffer from the tinnitus have another brain signature of their tinnitus. And we have established treatments, and these are counseling, cognitive behavioral therapy, sound therapy, with hearing aids especially, and neuromodulation. And I think it's essential that we offer these treatments that are already there. It's unfortunately still much too frequent the case that tinnitus patients receive the message there's nothing that can be done, and this is just not true. We have efficient treatments. We have no efficient treatments to really stop the tinnitus or to reduce the loudness of the tinnitus, but we have efficient treatments to reduce the impairment of the tinnitus, and these treatments should be offered. Thank you very much.
Thank you so much, Berthold. Very, very interesting. So that finishes our speaker presentations, and we will now progress into our panel discussion. Obviously, we don't have Dr. Bennett with us, but maybe there are some questions which our other experts will be able to give some perspective on. Just to let Berthold just regather his thoughts, I'll come to David first of all. David, just a very basic question. First of all, some of the research that you shared, you talked about samples of people that you've been interviewing, and there's just an inquiry here about whether they were just audiologists or whether in fact there were some medics in there, some ENTs, etc.
So we didn't include ENT specialisms, but what we did have is audiologists working in the NHS and also independent sector hearing aid dispensers and audiologists. And actually, initially, we had quite high uptake for those working in the independent sector, possibly because they have more time and just seem to be much more willing to take part in the research. But we were able to increase our NHS audiologist sample as well. So no to ENT kind of surgeons and those working in those kinds of departments. That said, it's a really great suggestion and something that we could possibly look into and explore further. So yeah, just audiologists and hearing aid dispensers primarily. But as you can appreciate, these are working clinicians, so they have very limited time to take part in research. So it has been tricky just to get the smallish samples that we already have.
Thank you, David. Just another question to you, actually, regarding some of the questionnaires that are being used within the sort of the assessment, really, and whether there's any recommendations on surveys that we might be able to use that give us that kind of baseline for monitoring of health conditions and hearing, anything that you think could already be utilised in daily practice?
Yeah, absolutely. I mean, I see it's the question from Nicole, isn't it? In the discussion, it was a really great question, and I think Nicole was saying they already use some baseline intake forms. So I'd be quite interested in terms of what they're using. In terms of our research, looking at kind of social isolation, loneliness, and so forth, we typically use validated measures. So the ones that we've used in our research are the UCLA. I looked it up while I saw the question pop in. The UCLA
cheating, David.
Yeah, I know. The UCLA loneliness scale, and also the Lubin social network scale. Now, what's great about those scales is they're really short. So the Lubin, for instance, which is looking at friendship and family relationships and is a really good indicator of loneliness and withdrawal, only includes 6 questions. So in clinic, in theory, it would be quite simple and straightforward to implement without taking up too much time, because I appreciate time is a commodity in the clinic. We've also looked at very short scales in terms of depression, anxiety, as well as good metrics. So I would recommend in clinic any measure. It doesn't have to be validated, to give you that kind of insight into this is where somebody is pre-intervention and then post-intervention as well, because we tend not to have robust evidence that looks at that. But anecdotally, as clinicians, they will know that it does have a benefit. So it's just documenting that, which I think is really good.
An observation made through the presentations we had is that women are impacted more with loneliness, and I wonder from both of you, Berthold and David, whether that was a factor that's shown up in some of the work that you've done, really, in terms of, are women more impacted by the higher anxiety and loneliness that occurs with either tinnitus and hearing loss, or either single disorder? Perhaps Berthold, you go first.
Yeah, so from tinnitus research, we know that the reaction to tinnitus differs between men and women. So other aspects from tinnitus are bothersome and stressful for women than for men. But I'm not aware of any specific study investigating the effect of loneliness. I think we have the main problems occur both in men and in women, and I think the negative impact of loneliness on mental health and cognition and emotions, they are well studied, and there might be slight details, but I would not say that in general women or men are more resilient for the effects of loneliness. I think it's a very important risk factor for both genders.
Thank you. David, any thoughts or observations in any of the work you've done?
Yeah, I would definitely agree with Berthold. We tend not to find any associations with gender or sex primarily. So what we do in some of the work that we've undertaken is we often include that as a variable, and we don't find that it's predictive above and beyond age. So if we enter age into our kind of models that we use, we tend to find that basically is the driving factor, as well as severity of hearing loss primarily as well. So I am aware of some research showing that the incidence of hearing loss in particular is slightly higher in males than females. However, we don't tend to find a relationship between social isolation, loneliness specifically. But I think it's also worth noting that so if we take social network size, for instance, for one specific demographic, social network size might be quite small versus another, but actually the extent to which that's important might be different as well. So I think this goes back to what I was saying about holistic, person-centered care, is that we might find some of these associations with certain subgroups. However, we need to look at the individual at that level to see what's important to them and how we can mitigate those risks, which I think most healthcare professionals already do. So like I said, very similar to Berthold, we don't tend to find those. Not sort of say they don't exist, they just don't explain lots of the variants that we see in some of these domains.
Okay. You started to talk really about the Unity study, I think it was, where you were looking at either single interventions or combinations of interventions, and that the combinations had a better outcome for people generally. You moved on to talk about the neuromodule stimulation and this kind of bimodal sensory stimulation. And I wondered, have you then looked at that bimodal sensory stimulation and something like CBT together, and what outcomes might have been there?
That's a very good question. The difficulty with all these combination studies is that they are methodologically difficult to perform, because you always have different conditions like treatment A, treatment B, combination of treatment A and B, and some control group. So therefore, there are not yet any studies investigating the combination of CBT and bimodal neuromodulation. But based on what we have found in the large study, it's probably the fact that it makes sense to combine different treatments. So more or less what we found in this alone in the study, looking on treatments alone or in combination, that we have an additive effect. So for sure, if you have a treatment with low efficacy and you add another treatment with higher efficacy, so both together are better than the treatment with low efficacy. If you already have a highly effective treatment and you add another treatment, you don't win anymore so much. But so in general, I think we have additive effects, and there's no reason why not combining different treatments in order to achieve the best benefit for the individual patient.
Okay, thank you. Now I have a tinnitus expert and a psychologist online with me. Brings me to my next question, which is, you've mentioned, Berthold, about the value of CBT as an intervention therapy. And of course, I'm very well aware that psychologists have got years of training and it's a very specialist area. But what is the role, do you think, for empowering and helping people positively for audiologists or general practitioners, etc.? How could we get that balance right, where we may not have direct access into referring straight to a specialist?
I think that's an extremely important question, and there's a huge problem with the availability of psychotherapy, and it's not only the capacities of psychologists, it's also whether the patient has the time to go there, whether the patient knows the right language, but the same language like the therapist. So that's a big problem. And I think the scientific studies have shown that first, it's possible to train audiologists to perform cognitive behavioral therapy for tinnitus patients. The results are equally well like results from psychologists. And I think there's an increasing amount of app-based or online-based psychotherapy. And also here we see quite good results. The largest difference is the adherence to the treatment. For sure, if I use an app, I really have to use it in order to have the benefit. If you have an appointment, either with a psychologist or an audiologist, I rather go there. I don't kit treatment. The adherence is higher under these conditions. But in principle, the CBT-based approaches are effective, whether they are applied as face-to-face treatment by a psychologist, by an audiologist, but also app-based. So I think we really have to think about possibilities to make this available to the patients. And I'm very much in favor that audiologists are trained to provide cognitive behavioral therapy. This is not rocket science. This people can be trained. For sure, we have always the situation that we might have very severely impaired patients with severe depression, with severe anxiety, with suicidality. So it's important to identify these patients and refer them to the psychiatrist, the psychotherapist. But I think in general, these kind of providing strategies and competencies to cope better with the tinnitus, this can be provided by audiologists.
David, your thoughts?
Yeah, I would say this is a really interesting question, Karen. And to go back to what you asked in terms of empowerment, how do we empower, audiologists, hearing healthcare professionals to kind of embark on some of these endeavours? One of the interesting findings we've found in our research is that often they are willing, but they lack the confidence to do so because they don't have that knowledge, they don't have the skills, the training in order to empower them to do that. And actually, they really do want to do those things. As an aside, I often feel I'm not very popular with British audiologists because I know they have very limited time in clinic, and I'm asking them now also to embark on conversations about general health, which is for some beyond the remit of their clinical experience, and they're often concerned about engaging with client service users just in case they offend them. You don't want to stereotype people just based on a short interaction with them. So I know that there is some resistance there. So I don't think it's necessarily adding to the workload because there are other strategies that can empower audiologists. So it might be, you don't have to have a long discussion about general health or about psychological well-being, but here are some resources that I have available to me that you as an individual can go outside of the clinic and look at. So I guess it's just giving clinicians small nuggets in there. I always call it a toolkit. So they've got their toolkit and they can pull out a resource, or they can highlight, say, an app or something and say, I think you would benefit from that. So it takes a minimal time, but then also provides them that, I call it self-efficacy, so that confidence that they're not going beyond their clinical remit, but are still helping ultimately. I would also love, if it was possible, this is a big ask, is that audiologists could onward refer to other healthcare specialisms, and that's something that we did recommend, that we often operate in our silos. And actually, what we should be doing is that I call it making every contact count, which is part of an NHS initiative, where if an individual's going to a healthcare professional, irrespective of what they are, and they notice, oh, actually, you might benefit from another service, that they can cross-refer, and so you're not constantly going through the same system of GP refer, and so forth. But these systems are often complex to navigate and unwieldy, and that isn't always possible. So yeah, hopefully that that kind of answers
And I
your...
think it's interesting because across all three presentations, we really heard the importance of awareness, of intervention, of positive framed language. So, for instance, but to tell somebody there is nothing that can be done is, not true. I guess what is our role? Because as you say, David, it's a multidisciplinary approach to educate not only the professionals but also the general public around the importance of interventions and being informed. So, I mean, what as a profession across all the different disciplines should we be doing really to kind of move the dial a little bit on this?
Is that question to me?
Yeah, generally, yes.
I wanted to pause and think, because it's a very loaded question to answer, and I don't think there are any easy answers to that question, because we are navigating in a complex world. But I think going back to what you were saying, I think it takes an innovative approach. I think in terms of increasing awareness, both within the general public and with clinicians themselves, I think there needs to be better signposting to different resources. We need to think about streamlined, simple approaches that don't take up too much time, too much resources. And I think we all need to be responsible for our own health, primarily as individuals, and also to be confident to make those signpostings, and to be confident that as healthcare professionals, we don't know all the answers, but we can find someone who does. So I guess it's being confident about not being confident, or being comfortable with being uncomfortable, I guess, in a way. So we need to very much be open that we might not have all of the answers. And I know that can be incredibly awkward in a clinical consultation, but I think some people just need reassurance that I can't help you with this, but I can find, I can try and help you find something that will help.
Yeah. Any further perspectives to add to that, Berthold?
Yeah, I think it's a very, very important issue, because my impression is that the awareness about the relevance of hearing loss and tinnitus and what can be done in the general population is much too low. And for sure, the question is how to change it. But I think we have very efficient treatments for hearing loss, but many patients who have hearing loss do not receive hearing aids, and many of them who receive them, they do not use them because they do not experience the improvement. And I think all these long-term effects, like reducing loneliness, reducing cognitive decline, there's no awareness for that. And I think that's really important to increase this awareness. And we have a similar situation also in the tinnitus field, that in the study which I presented, we offered cognitive behavioral therapy for free to the patients. And these were motivated patients. They engaged in study participation. But still there, about 50% of the patients dropped out. They didn't, as soon as they were randomized to cognitive behavioral therapy, they told us, oh, no, I wanted a hearing aid, but CBT is not what I wanted. So we have to explain to the patients how this will work, because the patient comes and expects a treatment that reduces tinnitus loudness. And it's not that the patient is motivated when you say, okay, we offer you CBT. We have really to explain to the patients how this can work and how this can reduce the burden of tinnitus. And this is a real challenge. And I think the matter of time came up. Whoever deals with the patient, the general practitioner, the ENT doctor, the audiologist, all have little time, and this requires time to explain how these mechanisms work. So I agree, we have to increase awareness in the general population. We have to increase awareness among patients and among healthcare professionals to really apply the available treatments to the patients.
Thank you. Just some very practical questions for you now, Berthold. Some of the therapies that you've been talking about, do they work directly with hyperacusis as well?
It's a very good question. So we just looked on on the impact of hyperacusis on the treatment success. And because there's always the discussion whether patients who have tinnitus and hyperacusis are a specific subform of tinnitus and they have specific response to a specific treatment. And what we found for every single combination, there was no difference in the response whether patients had tinnitus plus hyperacusis or tinnitus alone. What we did not analyze yet, because we have a huge amount of data, is whether we assessed the amount of hyperacusis, but whether there was any impact on hyperacusis specifically, we did not analyze yet. But hyperacusis was not, or the presence of hyperacusis was not a specific predictor that you would say if you have tinnitus plus hyperacusis, hearing aids, you benefit more from hearing aids than if you have tinnitus without hyperacusis.
In the model that you presented to us about the way that you approach sort of people that are presenting with tinnitus, whether it's with a headache or with vertigo, etc., so is part of the batch of the assessment that you do, somebody is asking, is that the classic kind of psychoacoustic testing where you try and do some pitch match frequencies and measure residual inhibition? Is that still something that is done? And also, is there a model or guide that people could adopt that you would suggest is a useful way of trying to assess tinnitus to then think about what would be the treatment? So just a kind of combined question there, just to wrap us up.
Yeah, so when we first came up with such a suggestion, we differentiate between essential tests and tests that can be done. And I think an audiogram is essential in every tinnitus patient. We should know about the hearing function of the patient. Additional tests like high frequency audiogram are helpful sometimes, also frequency matching, residual inhibition, minimal masking level, that can be helpful. We regularly do it, and typically it also helps in the counseling of the patient, that we explain the patient that the tinnitus pitch is near their hearing loss, something like that. So I think that's helpful. I would not say it's so essential for the management, not so essential as a audiogram. Otherwise, we as medical doctors, for sure, we want to have a complete case history, and we want to know about comorbidities because they have an impact on treatment. For sure, if somebody has episodic tinnitus and migraine, this could be related to each other. If somebody has typically vertigo and tinnitus and low frequency hearing loss, so this could be Meniere's disease. All these aspects are important, not to overlook these different conditions that are related to tinnitus. And the same is true also for psychiatric comorbidities like depression, anxiety. And another aspect we did not discuss yet is the influence of the somatosensoric system, the temporomandibular joint disorders, neck problems. So I think we heard about the holistic approach. Also from a medical perspective, this holistic approach is desirable because frequently we find something that helps us where we can help the patient. So if somebody has tinnitus related to problems with the temporomandibular joint, for sure this should be treated with physiotherapy in order to improve the overall condition. So I think that's important, not to look on the tinnitus alone and everything which is related. And in my clinical experience, a sentence that is very important is asking the patient, what bothers you most about your tinnitus? And sometimes it's, I can't fall asleep anymore. So we already have a first access to the patient. We say, okay, so we try to focus on the sleep. There are also specific behavioral techniques, there are specific medications that can help. So at least you deal with the problem which bothers the patients most. It can be something else, it can be communication difficulties. Then for sure, the first focus is to improve hearing in order to improve communication. So I think that's a very important question. What bothers you most about your tinnitus, and starting from there.
Thank you both. It's been very, very interesting. And I think the two words that we're taking away here is always holistic care. There's definitely a place for multidisciplinary approaches, and there is always something to try. So I think that's really important. So thank you, audience, for staying with us. Just as a reminder, we would welcome your feedback. That can be found on the forms here. So that will help us to shape future symposiums. Those of you that are from countries with the approval for continuing education points, you'll get notification of that tomorrow by email, and a reminder that the recording of this will also be sent out to you. So once again, thank you so much for joining us. Thank you to our speakers. Thank you to the team behind the scenes for helping us put the event together, and wish you all very well. Thank you.